Welcome to our video on Adrenal Glands Overview, Congenital Adrenal Hyperplasia, and Primary Hyperaldosteronism. Let's get started. Here is our overview slide. Let's begin by discussing an overview of the adrenal glands. The adrenal glands sit on the superior surface of the kidneys and consist of the outer cortex and the inner medulla. Histologically, the adrenal cortex consists of three important zones: the zona glomerulosa, zona fasciculata, and zona reticularis. The primary functions of each of these three zones can be remembered with the mnemonic go find rex, make good sex. So the G in go stands for the zona glomerulosa, the F in find stands for the zona fasciculata, and the R in rex stands for zona reticularis. And the M in make stands for mineralocorticoids, the G in good stands for glucocorticoids, and finally the S in sex stands for sex hormones. So the zona glomerulosa makes mineralocorticoids such as aldosterone, the zona fasciculata makes glucocorticoids such as cortisol, and the zona reticularis makes sex hormones or androgens such as dihydroepiandrosterone or DHEA. The adrenal medulla, on the other hand, is responsible for the production of epinephrine and norepinephrine. All right, now that we've given an overview of the adrenal glands, let's move on to discuss congenital adrenal hyperplasia. With regards to this topic, we'll be discussing the definition, etiology, pathophysiology, clinical features, diagnosis, and management. Congenital adrenal hyperplasia is a genetic disorder of the adrenal glands that leads to impaired enzymatic function and steroid production. The defect is usually in one of these three enzymes: 21-hydroxylase, which is most common, 17-alpha-hydroxylase, and 11-beta-hydroxylase. Regardless of which enzyme is deficient, congenital adrenal hyperplasia is almost always a product of an autosomal recessive mutation. Let's examine the pathophysiology of congenital adrenal hyperplasia using this figure, which illustrates key enzymatic reactions that take place within the adrenal cortex. A deficiency or absence of 21-hydroxylase slows down the production of aldosterone in the zona glomerulosa, and cortisol in the zona fasciculata of the adrenal cortex leads to the buildup of progesterone and 17-hydroxyprogesterone. Excess progesterone and 17-hydroxyprogesterone get shunted to the right of this pathway, where they're used to produce androgens like testosterone in the zona reticularis. Overall, the deficiency of 21-hydroxylase leads to a decrease in aldosterone, a decrease in cortisol, and an increase in androgens like testosterone. In response to low serum cortisol, the body releases a greater amount of ACTH, which in turn stimulates the adrenal glands, leading to adrenal hyperplasia. This is why a deficiency of 21-hydroxylase leads to adrenal hyperplasia. Examiners also want students to know that there are two general types of congenital adrenal hyperplasia: classic and non-classic. Classic congenital adrenal hyperplasia results from a complete deficiency of 21-hydroxylase, and it presents at birth. Non-classic or late-onset congenital adrenal hyperplasia, on the other hand, results from a partial deficiency of 21-hydroxylase, and it presents later in life, usually during teenage years. The clinical features of congenital adrenal hyperplasia are best understood in the context of the hormonal changes seen in these patients. Patients with classic congenital adrenal hyperplasia have a complete deficiency of 21-hydroxylase, which means they cannot produce aldosterone or cortisol and produce an excessive amount of androgens. The near absence of aldosterone and cortisol leads to profound hypotension and dehydration, largely due to salt wasting. The excessive amount of androgens, on the other hand, leads to an enlarged penis or scrotal hyperpigmentation in newborn males and ambiguous genitalia in newborn females, for example, clitoromegaly. In contrast to patients with classic congenital adrenal hyperplasia, patients with the non-classic variant only have a partial deficiency of 21-hydroxylase. This means that these patients still have some aldosterone and cortisol to maintain their blood pressures and only have modestly elevated levels of androgens. For that reason, these patients usually have normal blood pressure and normal appearing genitalia, and instead present with signs of chronic progressive hirsutism rather than full-blown virilization. Notable clinical features include acne, increased bone age and growth, oligomenorrhea, and signs of precocious puberty, such as early pubic hair growth. When it comes to the diagnosis, classic congenital adrenal hyperplasia is typically diagnosed with elevated levels of 17-hydroxyprogesterone on newborn screening. It's important to know that examiners sometimes refer to 17-hydroxyprogesterone as 17-OHP in question stems, so make sure to know both of these names. Non-classic congenital adrenal hyperplasia can be diagnosed with elevated serum 17-OHP levels as well as an ACTH stimulation test, which is considered positive if levels of serum 17-OHP increase significantly following the administration of synthetic ACTH. Lastly, both classic and non-classic forms of congenital adrenal hyperplasia may lead to hyponatremia, hyperkalemia, and hypoglycemia. Hyponatremia and hyperkalemia occur due to a deficiency in aldosterone, whereas hypoglycemia occurs due to a deficiency of cortisol. The management of classic congenital adrenal hyperplasia is with replacement of mineralocorticoids and glucocorticoids, as well as adherence to a salt-rich diet. Non-classic congenital adrenal hyperplasia, on the other hand, is treated with low-dose exogenous steroids, such as hydrocortisone. All right, let's try a question. A 5-day-old girl is brought into the ED with severe vomiting. She was born at 39 weeks gestation at home. Her blood pressure is 38/21 millimeters of mercury. Physical examination is notable for signs of dehydration and an enlarged clitoris. Laboratory evaluation is notable for hyponatremia, hyperkalemia, and elevated levels of 17-OHP. What is the most likely diagnosis? All right, the most likely diagnosis is classic congenital adrenal hyperplasia, likely secondary to a deficiency of 21-hydroxylase. This diagnosis is strongly suggested by profound hypotension, signs of dehydration, and clitoromegaly in the context of hyponatremia and hyperkalemia. That being said, it's truly the elevated levels of 17-OHP that give away this diagnosis. Okay, let's move on to the final topic, primary hyperaldosteronism. With regards to this topic, we'll be discussing the definition, etiology, pathophysiology, clinical features, diagnosis, and management. Let's start with the definition. Primary hyperaldosteronism is characterized by excessive production of aldosterone by the adrenal glands. The most common etiology is bilateral adrenal hyperplasia, followed by adrenal adenoma, which is also known as Conn syndrome, and adrenal carcinoma, which is very rare. Regardless of what's causing the elevated levels of aldosterone, the excess aldosterone increases renal sodium absorption, leading to retention of water, potassium secretion, leading to hypokalemia, and hydrogen ion secretion, leading to metabolic alkalosis. The classic presentation involves a young patient with resistant hypertension and hypokalemia. All right, let's try a quick question. What is the likely etiology of resistant hypertension and hypokalemia in an elderly patient with a history of hyperlipidemia? All right, the most likely etiology of resistant hypertension and hypokalemia in an elderly patient with hyperlipidemia is renal artery stenosis. This happens because high cholesterol levels lead to stenosis of the renal artery, which then leads to activation of the renin-angiotensin-aldosterone system. This in turn leads to excessive production of aldosterone and subsequent hypertension and hypokalemia. Therefore, it's important to remember that in a young patient, resistant hypertension and hypokalemia likely means primary hyperaldosteronism. However, in an old patient, resistant hypertension and hypokalemia likely means renal artery stenosis. The diagnosis usually begins with detection of hypokalemia in the context of resistant hypertension. The clinician may then order and compare a ratio of serum aldosterone levels to plasma renin activity, which is considered to be the most sensitive screening test for primary hyperaldosteronism. Generally speaking, a ratio of greater than 20 is consistent with a state of hyperaldosteronism. Some clinicians may elect to confirm the positive aldosterone to renin ratio with a salt loading test by giving the patient either oral salt tablets or IV normal saline. This is the most specific screening test for hyperaldosteronism, and it's considered positive if serum aldosterone remains high despite suppression of the adrenal glands with high levels of salt. Once the diagnosis becomes likely, clinicians may order adrenal venous sampling to establish whether high levels of aldosterone are coming out of both adrenal glands, which suggests bilateral adrenal hyperplasia, or just one of the glands, which suggests either adrenal adenoma or carcinoma. Similarly, CT or MRI of the abdomen with contrast can help clinicians directly visualize the adrenal pathology and determine whether the problem is bilateral or unilateral in nature. Here's a CT scan of the abdomen depicting a right-sided adrenal adenoma. By means of orientation, here's the liver, the right kidney, and the notable tumor sitting atop the right kidney where the right adrenal gland should be. The management of primary hyperaldosteronism depends on the exact etiology. Patients with bilateral adrenal hyperplasia are usually managed with either spironolactone or other aldosterone antagonists, such as eplerenone. Patients with adrenal adenoma or carcinoma, on the other hand, are usually managed with surgical resection, although the care of these patients may get quite complex and most of it's beyond the scope of step 2. All right, let's finish up with the final question. A male patient with unknown hyperaldosteronism undergoes adrenal venous sampling, which shows elevated levels of aldosterone in veins of both the left and the right adrenal gland. What is the most likely etiology of this patient's hyperaldosteronism? All right, the most likely etiology of this patient's hyperaldosteronism is bilateral adrenal hyperplasia. This is because adrenal venous sampling showed that both of his adrenal glands are producing high levels of aldosterone. In bilateral adrenal hyperplasia, both glands will be responsible for high levels of aldosterone. In adrenal adenoma or carcinoma, on the other hand, only one of the adrenal glands produces high levels of aldosterone. So again, the answer is bilateral adrenal hyperplasia. And that concludes this section.